your head together for a bright and shiny future with patient safety and quality healthcare. We are NABH, your healthcare companion, standing right by your side.
Good evening, everyone. Thank you very much for taking your time and joining this free webinar series of CAHO, the 18 new. There have been several requests from stakeholders across the country requesting for clarity on the 18 mandatory indicators, the clinical indicators that have come in NABH 6th edition. So the PSQ 3 of the NABH standards talk about, I'll read it out. It reads as follows. The organization identifies key indicators to monitor the structures, processes, and outcomes, which are used as tools for continual improvement. So there it is explicitly mentioning all the indicators that we are already capturing. And then they have said, quality indicators pertaining to clinical specialties and subspecialties have been added in the key performance indicators for greater involvement of clinicians in the quality improvement program. Few of these indicators have been mandatory for the organization as per the scope of services. And then a reference to NABH key performance indicators. These indicators are based on available literature or created in accordance with good practice. Every indicator shall have a defined numerator, denominator, and multiplier. Where appropriate, the definition of terms shall be provided. So this is a very broad statement with about 18 mandatory indicators that have been included, but with very specific note that it depends on the scope of services of the organization. Now, if you're not offering cardiology under the scope of services, then you don't have to get into monitoring the cardiology indicators. That's exactly what it specifies. So to have better clarity on these clinical indicators, we thought it's important to have a free webinar on these indicators. We couldn't think of anyone else but Dr. Narayan Pense and Dr. Sunil Mundkur for the first set of indicators. And the next week, we have two more experts joining us, Dr. Sanjeev Singh and Dr. Nirmal Frederick. I'm sure it's going to be an academic feast. All your queries are going to be answered. So we have structured this webinar in such a way that Dr. Narayan will be handling the first 5 indicators, followed by Dr. Sunil Mundkur on 4 indicators. And thereafter, there'll be a very elaborate question and answer session. And I'm sure they'll clarify all your doubts, which is why we have given 1.5 hours time. So this is going to be a great session, and I don't want to stand between you and the session. So let me first take the time to introduce Dr. Narayan Pense, though sir needs no introduction. He's a great partner of CAHO, committed to the mission of sharing best practices, quality, patient safety, and accreditation, a champion to the cause. So he's a VP Medical Strategy and Operations at Fortis Healthcare Limited. He's an expert in this field. I have seen personally the indicators they capture at Fortis. So we thought it's very important that we listen to him. He's going to be spending quite a lot of time with us on explaining the indicators, the first set of 5 indicators. Over to you, Narayan, sir.
Thank you so much, Dr. Lalu, and thank you so much, Kaho, for this opportunity, and good evening, everyone. Let me just share my screen. Just give me a moment, please. Okay, can somebody please confirm if my screen is visible in presentation mode?
It is, sir. It is, sir. Please go ahead.
Okay, fantastic. Thank you so much. So without much ado, let's quickly get into the meat of today's session. So today we are talking about clinical indicators, and like Dr. Lalu mentioned, we are talking about clinical indicators because NABH has introduced them in the 6th edition. I mean, they were there, but they have now made them department specific, etc. Is that reason enough for us to discuss clinical indicators? I honestly don't think so. The purpose of clinical indicators is not to meet the requirements or conformities of any accreditation body. Clinical indicators are valuable tools for healthcare professionals to assess, improve, and ensure the quality and safety of the care that they provide. Obviously, provide to our patients, and this is an example of patient centric care and monitoring of care. What do they help in? Well, they help in monitoring and evaluating the quality of care which is being provided, and more importantly, identifies opportunities or areas of improvement. They also help pinpoint specific issues for attention, and they overall help drive the improvement. So, the monitoring of a clinical indicator, the selecting of a benchmark, measuring where we are with respect to that benchmark, offers great opportunity for linking this to overall quality improvement and to clinical audits and improvements overall in clinical care. So there is a larger purpose which is there, which goes far beyond what an accreditation body or what NABH or JCI mandate. However, these accreditation bodies, they supplement or complement what we should be doing in the first place anyway. And thankfully, in the sixth edition of NABH, there is a great focus now on getting into some of the clinical areas. Now, when I say clinical areas, it doesn't mean questioning clinicians and people about their knowledge, or countering them that no, NABH says this, that's why you are supposed to do this. That's not the intent. While, of course, to make the standards and the KPIs more objective, NABH has defined some of them, and where required, it has gone quite, prescriptive as compared to the fifth edition. However, the guidance issued by societies, professional societies, journals, etc., remain supreme for clinical practice, and we should always keep this in mind. So, the focus this time in sixth edition is on clinical audits, on department specific KPIs, some of which we are going to discuss in this session, on clinical outcomes, and of course on PROMs and PREMs. So, overall, the focus is coming now into clinical care, into the actual care being offered to the patients and how to monitor. But please remember, there is a larger purpose and the flow of indicator. I think we'll be starting with the wrong end if we start looking at the indicators in the first place. What we should be doing instead is that we should try and remember that everything starts from evidence based medicine. It is evidence based medicine which actually comes out with the right kind of guidance in the form of guidelines, which help steward or foster the correct practice to be followed. They also give rise to different protocols which need to be implemented in different hospitals or different specialities. And from these protocols come indicators. So, merely learning about an indicator or just parroting the formula of an indicator, numerator, denominator, percentage, rate, etc., that's okay to begin with. But the wider purpose is not to simply monitor indicators, but trying to get this link from evidence based medicine down to the what is being monitored at the hospital or specialty level. And to give an example of this, so let's say for neurological stroke patients, there are various journals, societies, associations, etc., which come out with different guidelines. For example, the American Heart Association, American Stroke Association, ICMR has its own guidelines, Ministry of Health and Family Welfare of India has its own guidelines, WHO has its own guidelines, and from them, the healthcare organization is expected to derive its own stroke protocol, for example. And this stroke protocol should at least be picking up the salient points of these guidelines. And from this stroke protocol comes what parameter you are expected to measure. For example, for stroke patients, neurological stroke patients, it would be door to needle time. That is when the patient has presented to the hospital and when the thrombolytic agent has been administered. So this sequence or this chain of you know um, reasoning is very, very important for all of us to keep in mind. Please remember, many times the quality officers or quality executives are not from a medical or a clinical background. While some of this may appear difficult for them, or some over enthusiastic ones may simply because NABH has said, or this journal says so, or this guideline says so, may start questioning the clinicians at the hospital. And that is something which we need to avoid. overall. The idea is to engage them, the idea is to support them, the idea is to gradually bring them onto, if they are not already there, onto the quality journey and some of the ways to improve the quality of care. So getting into now these specific indicators, I'll be covering 5 of them. So the first indicator is percentage of patients with congestive heart failure with reduced ejection fraction who are prescribed beta blockers at discharge. So the important, text in this indicator I have highlighted for you: percentage of patients with congestive heart failure. Then there is a subcondition. Even in this set of patients with reduced ejection fraction who are prescribed beta blockers at discharge. At discharge means obviously this indicator applies to admitted patients or inpatients. Very briefly, again, it is very important to understand the why are we measuring this indicator, because unless we understand the why part, it will become very difficult for us to even talk to clinicians, rather than be able to help them. So one should understand this a little bit. The normal heart, the left ventricle is the main pump which supplies the blood, oxygenated blood, to all parts of the body. In case of heart failure, the cavity gets dilated and the volume that is being pumped everywhere gets reduced. And there are these medicines or drug class called beta blockers. They are known to be beneficial in heart failure and have certain cardioprotective effect. So that is the reason why they need to be, or they should be prescribed in cases of heart failure. But please keep in mind that medical science or clinical science can be quite complicated. And this is one such example. So while we understand heart failure, but heart failure has been categorized into 3 separate types, or rather 4, but commonly used 3. So one is heart failure where the ejection fraction, how much the left ventricle is pumping blood in one heart cycle, or in one pump, is referred to as the ejection fraction. So if the heart failure is with reduced ejection fraction, that is less than 40%, then it comes under this category which we are discussing today, which is heart failure with reduced ejection fraction. Another category is with mildly reduced ejection fraction, or heart failure with preserved ejection fraction. So what is known from the evidence-based guidelines is, for example, from the American Heart Association as well as from the European Society of Cardiology, etc., that in cases of heart failure, particularly those with reduced ejection fraction, where the ejection fraction is less than 40%, they need to be advised various classes of drugs, one of which is beta blocker, because like I said, beta blockers are known to have cardioprotective effect in heart failure patients. Obviously, in order to measure something or to frame an indicator, we need to have some basic formulas in place. So what is the numerator for this indicator? The numerator is the number of patients with diagnosis of heart failure with reduced ejection fraction, that is ejection fraction less than equal to 40%, detected on echocardiography. So this NABH, for example, has not defined. I have added it here so that there is objectivity, because there may be a possibility that the echo may not have been done for certain patients, but we need some objective criteria. And the best way or the standard of care for calculating ejection fraction is by echocardiography, which is available in all hospitals practically who run a cardiology specialty as part of their scope of services. There are other ways of calculating ejection fraction like CT scans, etc., but they are not considered standard. So that is why it is always better to insist on having an 2D echo at least to measure the ejection fraction. Now, somebody may ask, echocardiography done within the hospital, done at a private clinic, should that private clinic be NABH accredited or not? We need not get into all those details. For us, simply if the patient has a diagnosis of CHF and the ejection fraction is low as determined by the clinician to be less than 40% on echocardiography, that is acceptable. And if the patient at the time of discharge has been prescribed a beta blocker. The denominator, number of patients discharged with a diagnosis of heart failure with reduced ejection fraction. Now, if you see the NABH denominator, it says diagnosis of CHF. I have highlighted that here. Now, ideally, it should be that if the numerator is coming from this group of heart failure, the denominator should also come from the group of this heart failure patients, because these are the ones where the evidence-based guideline says that beta blockers cause the maximum positive effect. So ideally, it should come from here, though NABH says that it should be CHF, that is congestive heart failure. Now you are in a dilemma whether I should report this to NABH or whether I should report this to NABH. So what you can do is you can actually measure both denominators, because the amount of work that you need to do for both of them is practically the same. You will have to go through the discharge summaries. You will have to see whether there is a diagnosis of CHF or not. The only additional point you need to check is whether the ejection fraction is less than 40%, in which case it comes under reduced ejection fraction type of heart failure. So you can actually report to NABH what they are wanting. And for your internal purposes, because when you want to show this data to your cardiologists, etc., they would insist that the denominator should be matched to the numerator, because that's what the evidence-based guideline recommends. The formula is simple: numerator divided by the denominator into 100, because it's a percentage, and the frequency of reporting has to be monthly. Obviously, with every indicator, or any measure for that matter, we need to have clearly defined inclusion and exclusion criteria or an operational definition. So in this case, the inclusion would be all inpatients with congestive heart failure, that is a diagnosis known of congestive heart failure, and with reduced ejection fraction, that is ejection fraction less than equal to 40% on echocardiography. What would be the logical exclusions? Patients below 18 years of age, because most of the guidelines, they cover only adult patients. For pediatric patients or adolescents, there are separate groups of guidelines, although they are not as commonly framed as they are for adult patients, because that's what the large majority of patient group consists of. Patients with other forms of heart failure, that is preserved ejection fraction, we do not, or mildly reduced ejection fraction, we need not include them, because like I said, this is specific for reduced ejection fraction. Excluded outpatients, because it is a discharge that we are documenting whether the beta blocker has been advised or not. Obviously, for any medication, there can be people who are allergic to certain medication class, or where the use of these medications may be contraindicated. And this is one example where the questioning of the clinician becomes important or avoidable in that sense. For example, if patients who have already got a reduced heart rate or a reduced blood pressure or a second or third degree atrioventricular block or bronchial asthma, etc., in them beta blockers are either contraindicated or to be prescribed only with strict caution, and it may be a clinical decision to prescribe or not prescribe beta blocker in such cases. Discharges other than planned discharge or transfer, for example, LAMA patients, there may not be enough time to prescribe discharge medications. Death would obviously be excluded from this group. So similarly, you should discuss with your clinicians when you start monitoring these clinical indicators, for example, for what to include here, what not to include here, etc., so that that ownership with the clinician also gets established. Where do you capture this data? Because this data has to be coming from the discharge summary, because the indicator requires that this be beta blockers be prescribed at the time of discharge. So you need to check the discharge summary. Discharge summary in your hospital could be an EMR or an HIS generated summary, or it could be a physical case record, in which case you may need to audit the case files and the discharge summaries. If electronic data is being generated, an example of framing a query which could help you get this data from the software itself. You could also look at supplementary sources, for example, IP pharmacy or OP pharmacy records from where sale of beta blockers have happened to your patients. Who is responsible for collecting this data? Usually, this would be with the discharge department or the MRD, because the files are coming to them, and this responsibility could be given to an executive or a nurse from this area, or it could be the quality team. There are also different hospitals who have heart failure clinics or CHF coordinators, etc., who could be tasked with this responsibility. Typically, the data gets calculated retrospectively because it is to see with patients who have been discharged. So it would not be possible really or practical to do it at the time of discharge itself, although it would be ideal to do so if possible. And the report typically gets collated and shared at a monthly frequency. And you could create various dashboards once you have collected this data. For example, usual recommendation is to prescribe 3 beta blockers. So you could look at the percentage of prescription of each of them. You could also do a benchmarking, whether it is, for example, an ideal benchmark would be 100%, because we would want all our patients with CHF and reduced ejection fraction to be getting beta blockers, but it may not be practical to have 100%. So it could be a stretch goal. And based on your hospital's performance or starting point, you could start with somewhere around, say, 60%, and then set yourself a target of increasing and reaching higher and higher till the time, say, a 90 or above 90 percentage of benchmark would be achieved for your hospital. We move to indicator number 2, which is percentage of patients of myocardial infarction for whom door to balloon time is less than equal to 90 minutes. I'm sorry, I'm jumping from indicator to indicator. We will take question and answers, separately later. And I'm sure once you get the concept along the way, because some of these may be common between different indicators, so the approach will be clear to you. So this indicator is for myocardial infarction patients. The first one was also to do with cardiology. This one has also to do with cardiology as a specialty, because that's where acute coronary syndrome or acute MI patients are getting admitted. So percentage of patients for myocardial infarction for whom the door to balloon time is less than 90 minutes. And let's understand the reason or why this indicator is important in a little more detail. So fundamentally, in a myocardial infarction, what happens is that the artery gets choked and the blood supply to the distal muscle of the heart reduces. Now, you know that heart is basically a pump. It pumps at regular frequency or intervals to pump blood throughout the body, and it requires muscle to do so. Now, when that muscle itself is not receiving optimum amount of blood, it will not be able to do its job properly, because blood is the source of oxygen and energy, glucose, etc., to the muscle. So every minute or every second is precious, because the damage which happens to a healthy muscle once the blood supply gets clogged or blocked is very quick, and it can get into a permanent damage. So the purpose of quick intervention, quick diagnosis and quick intervention is to prevent the myocardium from getting damaged. Now, when the MI is detected, it can be of different types. Typically, it is classified into STEMI, which is ST elevated type of myocardial infarction, and a non-STEMI, which is non-ST elevated myocardial infarction. And we will come to this in the subsequent slide. But basically, what an acute MI requires, STEMI in 100% of the cases, unless there is a contraindication, is for the artery to be reperfused as soon as possible. So you pass a catheter from the femoral or radial artery into the coronary artery, and you quickly inflate a balloon there. The moment you inflate the balloon, and then maybe you need to place a stent or not, depending on the specifics of that case, the balloon opens up the artery and the flow gets reintroduced or re-established. Thus, the heart muscle distal to this block starts getting blood and starts working normally as it was before the block had happened. So it is very important to understand the type of stroke, cardiac, stroke, and the intervention accordingly. So the door to balloon time is classically captured for the type of myocardial infarction, which is known as ST elevated myocardial infarction. What do we mean by ST elevation? on ECG, a particular segment which is called the ST segment is the one that is called ST elevated MI. While if it is flat and the patient still has got stroke or symptoms of stroke, it typically would be called a non-STEMI infarct or a non-STEMI stroke, cardiac stroke. Now, in case of ST elevated MI, the procedure which needs to be done to start the reperfusion of the artery is called a PCI, percutaneous coronary intervention, because like I said, the catheter gets introduced from the femoral or the radial artery, and it is used to open up the blocked artery very quickly. And the time taken from the time the patient arrives in the hospital till the time the diagnosis is made, the patient is taken to the cath lab, because that is where this procedure takes place, and the balloon is introduced and opened in the blocked artery, it should be less than 90 minutes. So that is what the measure is all about, or this indicator is all about. What is the evidence for this? Well, there is plenty of evidence for this and has been around since a long time. In fact, this is from almost 13 years, 12 years ago, that prompt PCI within 90 minutes reduces the mortality, that is chances of death, and the morbidity. And this is a class 1 evidence guideline, which is the highest level of evidence which is required. So when we do a PCI within 90 minutes for ST elevated MI cases, it reduces the risk of overall stroke, it lowers the chances of repeated heart attacks, etc. And it helps the overall long-term survival, that is better patient outcomes. The more the delay, the more the chances of death. So if you see here, mortality rate, when the PCI is done within 90 minutes, it is say 5%. The moment it starts going above 90 minutes, it starts up to 120 minutes, it is 8%. More than 2 hours, that's 120 minutes, it is in the range of 10%. So it has almost doubled in a short window of a few minutes. So that is the importance of the golden hour in case of STEMI patients. So what is this measure about? It is the number of STEMI patients. The numerator is the number of STEMI patients who receive primary PCI where the door to balloon time was less than equal to 90 minutes. Obviously, what would be the denominator? Number of STEMI patients, because these are the patients who require PCI within on the balloon to be inflated within 90 minutes. The formula would be simple: numerator divided by denominator into 100, because it's a percentage, and frequency of reporting is monthly. How do you detect STEMI versus non-STEMI? It is on ECG, and it should be defined clearly that what constitutes an ST elevation on ECG, so that there is no doubt left to anybody. And typically all this gets done in the stroke protocol. We need to look at inclusion and exclusion criteria for these patients also. So inclusion would be patients reporting with STEMI to the with STEMI diagnosed on ECG reporting to the ER. What would be the exclusions? So non-STEMI would logically be an exclusion. If the symptom onset for the patient has been more than 12 hours earlier, that is from the time that the patient is actually reported to the hospital, but the symptoms started more than 12 hours earlier, such patients do not benefit with a primary PCI and should be excluded from this formula. Patients received through referral from another hospital or facility. Many times the patient may have gone to a neighborhood hospital or a smaller facility without a cath lab, for example, or without a cardiologist being available at that time. And if such patient is received to your hospital, obviously such patients would be excluded because they have already been received delay, or their door to balloon would have started from the time of reaching that particular hospital. There are also medical reasons for not doing balloon inflation in certain group of patients. For example, if patients have active bleeding disorders, or if a cardiac arrest has already happened to the patient on the way to the hospital, etc. In our healthcare system, sometimes the delay also happen because the consent may not be given by the patients because of financial reasons or social reasons or some other reasons, etc. So if the consent has not been obtained in time, it would be logical to exclude them. Somebody may have a contradictory opinion and say, no, we need to include these cases also because it will help us keep account. feel free to do so. You can define your inclusions and exclusions accordingly, as long as they are in sync with the overall evidence-based guidelines. Typically, there would be a tracker in most of the hospitals or a data input sheet to capture the various time points, because here every minute is precious. So somebody will need to record the time that the patient has arrived into the ER, the time the triaging has been done, time the ECG has been done, time the cardiologist has been informed, time that the patient has been shifted to the cath lab, time that the skin has been punctured and the artery, the catheter has been placed and the balloon has been inflated. So all those times, and you can put in more times as per your requirement to be measured, so that this indicator can be measured effectively. Now, obviously, for any indicator, we need to capture enough data. For this data, there are two departments which are involved. One is the emergency department, and second is the cath lab, because the intervention is happening in the cath lab, while the patient's symptomatology and ECG, etc., typically would be done in the emergency department. So you may have to look at EMR, EHR, or your physical case records of the emergency. And also at the cath lab, most of the hospitals would have a cath lab register where all the details would be captured. You could also look at supplementary sources like HIS for billing charges, etc. Responsibility, again, it's an internal distribution or decision of the hospital, but typically there would be responsibility to somebody within the emergency department as well as in the cath lab. Some of the hospitals also have a stroke sheet or a STEMI sheet. They also announce a code like a STEMI code, etc., so that there is a team of people who responds to STEMI cases, and accordingly this can be measured and monitored. Obviously, there can be some gaps in data capture or practice if the time was not documented, or documented later, or was documented incorrectly. Sometimes simple things like synchronization of clocks between the two departments, even if there is a difference of, let's say, few minutes, it can create a lot of impact in the actual calculation of the indicator and the parameter. Typically, off routine hours, weekend days, etc., also there are misses which happen and cause a lot of delay. You could also create dashboards of these kinds. The one that you see on top is actually from my own hospital, where we measure our time for STEMI cases. So if you see, we instead of 90, we actually internally have kept our target as 75 minutes. So we were able to achieve in 63% of cases a time of door to balloon within 75 minutes, while up to 90 minutes, between that is 75 to 90, it was almost 14.5% additional, while in 21% of cases in this particular hospital in this particular month, it was 21%. And then we also defined what were the reasons for some of these delays. For example, delay in consent, financial clearance, delay in arrival of the team, delay in shifting to the cath lab, etc. So you can create dashboards and analytics, as per your comfort and convenience, and with the idea that you monitor what is the compliance percentage to this particular parameter. What you should also do, or can also do, is that you can also calculate the average or the median door to balloon time for that particular set of patients in that particular month, and see whether your overall median time is coming lower and lower or not, because it means that you are able to reperfuse more and more patients in a shorter window period. For example, for this hospital from 2015 to 2024, you can see that they are maintaining a very good door to balloon time. It's around 45-46 minutes for this particular hospital, which is a well established cardiac center. Obviously, when you collect data, you need to benchmark and you need to analyze. What should be a good benchmark? Well, obviously, one would expect 100% as a stretch goal, but at least more than 90% is a good benchmark to keep as an aspirational benchmark for your hospital. But discuss with your clinicians. Even if you start with low benchmark, the idea should be to get better and better, because ultimately in MI cases, TEMI cases, etc., every minute counts, and we need to make sure that we are able to intervene and reperfuse the vessels very quickly. Obviously, we already talked about practice challenges, off routine hours, cardiologist not being available on site, or cath lab technician not being available on site, or living far away from the hospital. So these are some of the practical challenges which come. And basis, once we start monitoring this indicator, we should drill down to these specific reasons, so that we are able to frame the intervention also required. Nowadays there are apps, etc., from pre-hospital care. That's even before the patient gets admitted to the emergency. The actual care starts happening in the ambulance.
Meenakshi, did we lose Narayan sir?
Yes, ma'am. I'm trying to call sir, ma'am.
I think sir is connected. He's having some network issues. Sunil sir, are you around?
Ma'am, he is logging in again, ma'am.
Okay, sure. Okay.
I am there.
Yeah. In case sir is not able to join, sir, you will be able to take it on, no? The second set.
No issues.
Thank you. Dear participants, we have some technical issues. Request you to kindly wait for a few minutes. Sunil sir, do you want to start?
I don't mind, but if you can give 2 minutes for sir to rejoin,
Yeah.
let's wait for 2 minutes.
I see him here connected.
I can see him.
Ma'am, he's having some audio issues, ma'am, I think.
Yeah, Meenakshi, I think we'll proceed with Sunil sir and then Narayan sir can take on his two indicators are over.
Yes, ma'am, we can do that, ma'am.
Yeah, Sunil sir, carry on. So, thank you very much, Sunil sir. Dr. Sunil Mundkur needs no introduction again. Apologies, dear participants. We will have Dr. Narayan Pense joining us. He's finished with two indicators, the door to balloon and also the first indicator from cardiology. And so, Sunil sir, you will be handling 4 indicators. So, kindly proceed, sir.
Hope I am audible.
You are.
Okay.
So, Sunil sir, though he requires no introduction, let me take a few minutes. He is the professor of pediatrics from Kasturba Medical College, a faculty of KAHO, and has been instrumental in framing several training programs of KAHO. I truly appreciate your efforts, sir. Thank you very much for joining us. Over to you for the next set of 4 indicators, sir.
Thank you. Thank you so much. Before I start, please leave a message to Dr. Pense that I have started over.
Yeah, Meenakshi will inform.
Yeah, I'll do that, sir. I'll do that.
Okay. Sorry. Just give me 2 minutes to share my slides. Can you see my slides?
Still not there, sir. Just hold on. I think, yeah.
It has come, sir. Please make it full screen.
Okay, that's good. Is it fine? Is it on full screen?
It is, sir. Carry on.
Okay, thank you so much. Any brief introduction has been already given on these indicators and their usages in the practice. If you see, most of the hospitals, when we do the assessment and quality assessments, we see clinicians' participations in a very, very least number. Very, very few clinicians get actively involved in the quality management system. However, ultimately, the entire aim of accreditations or certifications or qualifications program is to impart quality care to the patients who come to the hospital. And ultimately, that is a clinician's job. If you see the NABH standards, there are nearly more than 630 objective elements, but only a few very, very hand-picked objective elements do address the clinical competence. For example, there is one in the COP1 which says that evidence-based medicine and clinical practice guidelines are followed. And there are some areas where clinical care pathways are mentioned. Apart from these, if you see the NABH standards, or for that matter, any quality management system standards, very rarely they directly address the clinical care that is being given in the hospitals. So as a good initiative from NABH, they have started these new clinical indicators. And my sincere message to all of you is please do not do it for the sake of NABH. Please do not do it for the sake of accreditations. These are all good clinical indicators which will help us to improve our performances in various clinical departments. And ultimately, the quality of the care is transferred to the patients who come to our hospitals. So with that brief introduction, I'll directly go to my indicators, so the 4 set of indicators, and I'll take not more than 20 minutes, I will assure you. And it will not be as elaborate as Dr. Pense was deliberating. And please note also that if there are any questions, feel free to ask, or you can post it in the chat box also, so that we can address it one by one. So the first indicator given to me was on the gastroenterology, that is percentage of patients undergoing colonoscopy who are sedated. Now, I was wondering when I read this indicator that why a patient who is sedated should undergo colonoscopy. Then I understood that this indicator is addressing colonoscopy that is done under sedation. So a common procedure where patients are given medications to relax and minimize discomfort during colonoscopy. The comfort during colonoscopy is very, very important, as that the patient will accept repeated procedures and be cooperative during the procedure. Why we need to have a repeated procedure is because it's a common practice in the Western world to do annual colonoscopy for any cancer, because it can detect early cancers and get the patient treated, especially colonic cancers. That's very commonly seen in the Western world. So they do annual colonoscopy, and if the first colonoscopy is painful, then they will not come for the annual checkup. That's why they say that it has to be done under sedation. And again, the cooperation of the patient is also important for this procedure. Sedation can range from mild to deep, that is potentially inducing sleep. I'm not going to discuss about mild, moderate, and deeper level of sedations. Mild sedation is where it's only oral medication. Moderate sedation is where there is a parenteral administration of sedatives. And in the deeper level of sedations, it may be monitored anesthesia care that is adopted for these kind of procedures. The type of sedation used is tailored to the individual patients and procedure, to what extent they are cooperative for the procedure that determines the type of sedation. This indicator is optional. If you, hello?
Meenakshi, can you mute yourself, please?
This indicator is optional. The frequency is monthly, and it should include outpatients also. This is clearly indicated by the NABH standard. It should include outpatients also, because most of these colonoscopy procedures are done on outpatient basis or daycare procedures. The formula is the numerator is the number of patients sedated for colonoscopy into 100 divided by the total number of patients undergoing colonoscopy. Very, very simple, straightforward formula. You can retrieve this data from EMR or HIS after entering the appropriate data. There should be provision for entering the manual or electronically collected data also. So all you need to do is you can directly collect it from EMR, and it's very, very easy once you implement ICD-11 coding, because ICD-11 has procedure-specific coding. There will be definitely a code for colonoscopy. So you can brush through your EMR to find out how many colonoscopies have been done based on the code for the colonoscopy. You can have apps or online forms to capture this data. Colonoscopy register can have this data. You can have a colonoscopy register in the scopy room if your colonoscopies are done in only one areas. In hospitals like CMC or Manipal, we have 3-4 areas where the scopies are being done. So you may have to collect this data for the final outcome. Who can collect the data? The scopy room nurse or gastroenterologist or PCC, patient care coordinators, can collect this data and give this to the data clinicians. I give one important message here is that when you are capturing, analyzing the data on the clinical indicators, please involve the clinicians. Please involve the clinicians. If you don't involve the clinicians, they will not agree to whatever data you publish, whatever genuine data you may have. They will not agree for it. So involve clinicians in this data collection and analysis. The classical or the ideal benchmark will be 100%. If less than 50, try to increase it by 20% annually so that it ultimately reach 100% by another 3 to 4 years. The common challenges in the data collection or practice include underreporting, wrong coding, acceptance to do the colonoscopy under sedation, documentation gaps, and adherence. So data validation need to be done when somebody is collecting the data for the quality team. So it's always better to do the data validation and see if the data is robust for interpretation. What are the advantages? It allows patients to feel comfortable, relaxed, and to experience little or no pain. And deep sedation allows patients to sleep through the procedure without remembering anything. So they will not have the bad remembrance of the procedure. The disadvantages is the drowsiness, impaired cognitive function for 4 to 24 hours following the sedation. And patients are unable to work or operate or a motor vehicle and require an accompanying person to drive back home. That is why most of the Westerns go very mild to moderate sedation. And once they recover from the sedation, they allow them to drive or they will have somebody to drop them. Let's try to understand what the evidence says. Sidhu et al., the British Society of Gastroenterology guidelines on sedation in endoscope, gastrointestinal endoscope. Please note that this is not only for colonoscopy, for the entire endoscopy. There are very fantastic 54 guidelines they have put on sedations during gastrointestinal endoscopy. You can Google it out. Very nice, guidelines are there. You can follow these guidelines. And if you see the global compliance to colonoscopy, Canada, United States, and Germany have a score of more than 85%, and Italy scores around 78%. Switzerland also scores around 8%. Spain still 20%. Please note that this is the data which is published in 2013. All of them have improved in their colonoscopy sedation rates, which has come almost to the 100% in most of these nations. What about India? I was googling out the studies in India, and I had got this study which is done in southern India. It was published in Indian Journal of Gastroenterology. An informed consent was routine practice in most of the centers. This was GI scopy studies done in 19 centers of South India. 13 centers had a written protocol for procedure risk assessment for sedation. 17 centers, 89.5% used monitor for all patients, and 2 centers used it only when the patient is sedated. Monitoring was by a nurse in 10 centers and a junior doctor in 4. Nurse was responsible for post-procedure observation in 11. And a post-sedation discharge protocol or scoring system was seen in only 7 centers. In 7 centers, that is 36.8%, were performing colonoscopy with sedation in more than 50% of their procedures. That means to say probably the Indian benchmark will be around 50 to 60% still. So we can try for 100% compliance, or if not, move towards 100% compliance. That's about colonoscopy. The second indicator which I would like to discuss is the respiratory or pulmonary medicine. Percentage of COPD patients receiving COPD action plan at the time of discharge. A very, very simple indicator. Again, it is not a very good clinical indicator, I can say, because it will not tell the performance of the department to a very great extent. COPD is a chronic obstructive pulmonary disease commonly seen in smokers. A COPD action plan is a personalized roadmap for managing COPD and helping individuals understand and respond to their symptoms, especially during exacerbations. The plan includes guidance on medication, when to seek medical help, and lifestyle adjustments with the aim of improving quality of life and reducing hospital visits. Compliance rate to action plan at discharge is the intent of this indicator. How often you have given, that means to say you are treating COPD patients, you are discharging the COPD patients at the time of discharge. How many of them have received COPD action plan? That is what this indicator measures. Again, it is optional indicator. Mandatory, it becomes mandatory if it is in the scope. If your pulmonary medicine department is in the scope of services, then you have to incorporate. Or even if it is in the adult medicine, if you are treating COPD patients, you can adopt this indicator. Again, I repeat, please do not do it for the sake of NABH. You can use this as a very good indicator from the medicine department if you do not have pulmonary medicine department, and if your medicine department is treating COPD patients. The frequency of calculating this data is monthly, and it includes OP and daycare because the treatment remains the same whether it's outpatient, inpatient, or daycare. The number of COPD patients provided with the COPD action plan at the time of discharge is a numerator divided by the total number of COPD patients discharged from the hospital in the same period multiplied by 100 gives the percentage of COPD patients receiving action plan. Now, you can retrieve this EMR again because COPD has a ICD code. You can follow this COPD ICD code and see all the patients by entering the appropriate data. There should be provision for entering them manually if EMR is not available. Can I have apps or online forms to capture in case of COPD? You can directly use these online forms or Google Forms or Microsoft Team forms. COPD register can have this data. You can have a COPD register in the pulmonary medicine department or in MRD, and data from MRD or discharge cell can give this data. And who can collect the data? It can be MRO, medical records officer, pulmonologist, or patient care coordinators can be utilized for collecting this data and interpreting and monitoring this data. Now, again, the ideal way of ideal benchmark for this is around 100%, but if less than 50, it increases by 20% annually. Please note that there cannot be any exceptions for this because it is the same for all COPD patients. Again, the common challenges in data collection may be underreporting. They may not report it as COPD, or they may be wrong coding, so you may miss a few cases, or acceptance by the clinicians to give this COPD action plan, or documentation gaps or adherence to this. So, of course, data validation need to be done when it is done by somebody else. Now the standard NABH also tells that you need to follow gold standards. Actions could include medications, advice regarding smoking cessation, and vaccination when appropriate. The global initiative, the gold stands for Global Initiative for Chronic Obstructive Lung Disease, where it says that you should have a diagnosis and assessment, initial of pharmacological and non-pharmacological management, follow pharmacological and non-pharmacological management of exacerbations, and management of comorbidities. This needs to be included in the action plan when you discharge the patient and address each one of them. This is one action plan which is by the Australian board on COPD patients, and it has a three color, that is red, yellow, and green. Green is safe. Yellow says that patients may require an observation, and red may require that you need to get admitted. It indicates the severity of COPD and patient may, because many of these patients will be on inhalers, many of them may be on nebulizers, many of them may be on home oxygen therapy. So you may have to identify what are the warning symptoms and signs at which they need to report to the hospital and get the expert treatment. What should be the key components of a COPD action plan in India, which should include medication management like inhalers, oral medications, and oxygen, recognizing and responding to symptoms like what I already explained, the green zone, yellow zone, and red zone, lifestyle adjustments like smoking cessation, avoiding irritants and diet and nutrition, pulmonary rehabilitation, and monitoring and follow-up regular health checkups and keeping records, the education and support, understanding the COPD access to support. So all these can be incorporated into patient information brochures in the local language as well as English, and can be given at the time of discharge as a separate sheet. Or you can have a QR code if the patient is smart enough to read the QR code and get this information. That also can be done. You can incorporate this as a QR code. These are just headings I have written. You can incorporate various treatments and other requirements of these action plans in your formats, in your discharge summaries as well. And you have to find out how many of these discharge summaries comply with the action plan. That's what you need to monitor in the indicator. The key considerations here, the COPD action plan should be tailored to each individual's specific needs and circumstances. So you cannot have a common action plan for every patient. You may have to modify, you may have to restructure it for tailoring, fitting into each individual. Patients should be actively involved in developing and implementing their action plan. It is not that we just give these formats and then leave it. Patients should understand and they should get actively involved in developing and implementing their action plans so that they come for regular follow-up and they do all these lifestyle modifications to prevent further progression of these chronic obstructive pulmonary diseases. Action plan should be reviewed and updated regularly, especially after any changes in symptoms and treatment. You may have to review the action plan, so it's not enough once to give and then say we are 100% compliant. You may have to review, and it's a dynamic process. So based on the patient's exacerbations and remission, you may have to modify these action plans. That's about COPD indicator. Coming to pediatrics, my core area, percentage of bronchiolitis patients treated inappropriately. Bronchiolitis is a common respiratory illness in young children and is primarily managed through supportive care, focusing on hydration, oxygenation, and symptoms relief. While some pharmacological interventions like bronchodilators and corticosteroids have been studied, their effectiveness in bronchiolitis is not consistently supported by strong evidence. We will look into that later. So the percentage of bronchiolitis patients treated inappropriately is the indicator name. It is optional, becomes mandatory if pediatrics is in the scope or pulmonary medicine is there in the department, and if children and infants are being treated by the pulmonary medicine, then this becomes mandatory indicator. The frequency, it's monthly. It includes IP and applicable to children less than 24 months. So beyond 24 months, most often we may not make a diagnosis of bronchiolitis. We make it into wheezy bronchitis or bronchial asthma or asthmatic bronchitis. So usually in the first year of life or first 2 years of life, we make a diagnosis of bronchiolitis. The numerator for this ratio or the indicator is number of patients treated inappropriately into 100 divided by the total number of patients with bronchiolitis. So ultimately, it's a total number of bronchiolitis cases you need to check. And this becomes very, very relevant and little more tricky in Indian scenario because most of these patients get treated on outpatient basis. Mild bronchiolitis patients get treated on outpatient basis in Western world, and we admit very severe and very severely distressed patients. So NABH also describes what is inappropriate treatment. In patient bronchiolitis, steroids, bronchodilators, and antimicrobials are not recommended and hence would constitute inappropriate treatment. The steroids inhaled or IV or parenterals, bronchodilators again inhaled or parenteral, and antimicrobials whether again oral or parenterals are proved to be useless because 99% of these bronchiolitis cases are viral. So easy to retrieve the data. J21 is the ICD code, can retrieve from EMR or medical records. HIS after entering the appropriate data. There should be provision for entering the manually electronically collected data. Can have apps on online forms to capture. The bronchiolitis register can have the data. We can have a bronchiolitis register to capture all the patients of bronchiolitis. And who can collect the data? It's a PSU nurse or patient care coordinator who can collect this data and give it to the pediatricians for analyzing the data. Again, benchmark is to be 100%. If less than 50, increase by 20% annually. This again benchmark is given totally by me. NABH has not mentioned it. Benchmark, you can have your own benchmarks. The idea is to improve on move towards 100%. Common challenges in India, again, underreporting and wrong coding, acceptance, documentation gaps, adherence, and the data validation need to be done in such situations. One query I had already got from some quality coordinator, that the compliance rate is almost like 0 to 10% in our hospital. So when I discussed this with the pediatricians, they said that we will not write the diagnosis as bronchiolitis. We will write something else. So documentation gaps, adherence, and acceptance may be challenge in many of the hospitals. So try to get these pediatricians involved in collecting this data and inform them. What the evidence is. The Cochrane review identified 30 trials involving 1992 infants that compared other than adrenaline with the placebo. No difference in the need of hospitalization or length of stay was observed. However, there was considerable heterogeneity in the studies, including the meta-analysis with the variable study designs, small sample sizes, and the lack of standardized validated outcomes. And a small group of children with bronchiolitis, especially those with wheeze without crackles and or a personal or family history of TOPI, may have bronchodilator responsive airway obstruction where bronchodilators may be indicated. This is what the evidence is. Please note that I read my Nelson textbook of pediatrics way back in 1995. So for 14th, 15th edition of Nelson. Now it is around 22nd or 23rd latest edition. Still, there is no mention of bronchodilators, antibiotics, or steroids in the treatment of bronchiolitis. The Horvath HCM et al. Children with severe disease or respiratory failure have generally been excluded during these studies, in most of these studies, what he has mentioned, and says that evidence cannot be generalized to these situations because the severe forms of bronchiolitis have been excluded in this study. The study says 1,284 out of 3,727 of infants had imminently life-threatening disease. However, only 104 were admitted to intensive care unit. So this could not be explained. If they are imminently life-threatening disease, why they were not admitted? So thus the actual illness severity of these children is unclear. This is important as bronchiolitis symptoms scores have been shown to improve following albuterol or salbutamol use. ICU admissions for bronchiolitis and are increasing in the United States. Inpatient albuterol use associated with the illness severity. In the United States, 36.4% of non-ICU bronchiolitis admissions, 47.5% of ICU admissions without invasive ventilation, and 68.4% of ICU admissions receive salbutamol. This is a very, very interesting study. So still the compliance even in the Western world is only 36 to 40% for not using bronchodilators or steroids or antimicrobials. So I think I have confused all of you enough. If you have a justifiable reason, in bronchiolitis, like patient has a severe wheeze or bronchodilator responsive wheeze, and he has enough evidence of antimicrobials. There's one study which did 6-hourly procalcitonin, and then they said that if there is a raised procalcitonin levels in bronchiolitis patients, you can use antibiotic. In India, we cannot do 6-hourly procalcitonin levels. So you need to know that if you are using antimicrobials, what is your evidence to say that as antibiotics are required? Of course, most of the bronchiolitis patients get admitted in the ward, and they will have some leukocytosis, elevated CRP, or procalcitonin, or ESR, which may require a bronchiolitis. And if you have a definite evidence of secondary bacterial infection, of course, there is no way to say that it is inappropriate to treat with antimicrobials in such situations. So as long as you have a justifiable reason to use bronchiolitis, bronchodilators and antibiotics, it becomes appropriate treatment for the bronchodilator. So it becomes a part of numerator that you have treated appropriately. So I'll stop at this point because it will be a lot of controversies on that. So I'll stop on that point. The fourth indicator which I need to discuss is on oncology. Very, very simple indicator: percentage of oncology patients who had treatment initiated following a multidisciplinary meeting or the tumor board. Tumor board is a multidisciplinary team including a group of specialists and other medical professionals who meet on a regular basis with an objective to collectively choose the most effective course of treatment for a patient. The clinico-pathological meetings, that's how it's mentioned in NABH standards, 6th edition, does not mention the frequency of the meeting. So it says that clinico-pathological meetings need to be conducted. However, it depends on the patient load. I was wondering why they have not mentioned the frequency. Please note that if it's an oncology specialty, every week you may be starting a new chemotherapy or a radiotherapy or a cancer treatment. So you may have to meet in the tumor board weekly. Or if your load is not so much, you can meet probably once a month and justify your use of chemotherapy or cancer therapy in these patients. So that's why probably they have not mentioned the frequency of clinical pathological meetings, especially for tumor board. The percentage, it is again optional, mandatory if oncology is in the scope, whether you have medical, surgical oncology, radiation oncology, palliative oncology, or in any combination or singly, you have to do discuss on the tumor board. Again, discussion frequency, the data capturing, data analysis should be monthly. It includes it's applicable to includes inpatients only because most of these are being treated as inpatients. And if you are managing the cancer patients outpatient basis, also it has to be included. Sorry, this is wrong. Number of new oncology patients, the numerator for this indicator is the number of new oncology patients who had treatment initiated following multidisciplinary team meeting or the tumor board discussions into 100 divided by the number of new oncology cases. Includes all disciplines. That means to say it may be pediatric, it may be radiation oncology, or any other matter for that matter, any other branch of oncology. Data source you can retrieve it from EM or HIS. There should be provision for entering the manual electronic or collected data. Can have apps or online forms to capture. Cancer oncology register can have this data. And who can collect the data? The oncologist, nurse, or patient care coordinator. Or you may have a tumor board coordinator who meets as per the frequency defined in your hospital's policy. So he can say that whether all the patients of oncology have treatment initiated following tumor board treatment. Again, benchmark is to be 100%. If less than 50, increase by 20% annually. This is just my one suggestion. You can increase it even to 100% by another 2 months or 3 months. The same challenges will be there, like under reporting or wrong coding. So better to have the tumor board registry, and there you will see whether it is discussed in the tumor board or not, and the number of cancer patients treated, you will get it from the MRD. So tumor boards are recommended but not always mandatory for all cancer patients. This is what evidence says. They are especially crucial for complex or challenging cases and are increasingly becoming a standard practice in cancer care, particularly at comprehensive cancer centers. However, nowadays, in majority of the centers, all the cases will be discussed in the tumor board, and then only the final decision will be taken whether to treat with the radiation, surgery, chemotherapy, or palliative care. Tumor boards provide a forum for review of multidisciplinary considerations, patient-specific factors, and tumor-specific recommendations that influence effective application of the guidelines to ensure that care is tailored to each patient and to optimize management across various cancer types. Many institutions are working towards making tumor board participations mandatory or linking it to privileges and reimbursements to ensure optimal patient management. Ultimately, all these will reflect onto the patient care, and patient will be beneficial at the bargain. So that is the end of my 4 indicators. Over to you, Lalu, ma'am.
Thank you. Thank you very much, sir. Please stay back. There'll be questions, I'm sure. So before we hand over to Dr. Narayan Pense, who will be joining us shortly, I would like to put up information about a program that we are going to be hosting very shortly. This is on clinical indicators, and this is a masterclass series that we are going to be hosting, empowering clinical excellence, clinical indicators. It's going to start from the 8th of August, every Friday. It's for 1.5 hours. So we thought it's important just not limiting ourselves to the 18 mandatory indicators of NABH. However, getting the clinicians involved, as Dr. Narayan Pense rightly said, this is one way that we really need to use this exercise to get our clinicians involved in the quality improvement exercise. So unless we really work with the clinical departments, the outcome improvement can never be measured. So it's important that we go department-wise. So what we have done is we've identified certain hospitals of excellence that are actually monitoring indicators in their own hospitals and setup. And every week we are going to be addressing a clinical department, starting from emergency medicine, anesthesia, critical care by Aestadium, followed by cardiology and cardiothoracic surgery by Fortis Healthcare Limited, obstetrics, gynecology, then pediatrics, neonatology. So we have the entire gamut of all clinical departments covered by specific hospitals that are already covering. So we will get to see how they are doing this, and also the benchmarking. So that's the idea. So if you have not registered for this program, kindly use the link that is going to be shared by our team and register for this program. It's going to be almost for 18 weeks, 1.5 hours. You can even invite your clinicians of the respective departments to join this program. The first-hand information from the clinical experts will be very useful to motivate your clinical departments to take part in this outcome exercise. Next slide, please. Yeah, so these are the hospitals that are going to be presenting as part of this masterclass series of CAHO. Next one, please. So this is a program which is chargeable. So we are going to be, for members, we are going to charge about 4,500 for the 18 masterclass, 18 weeks of program, 18 sessions, and non-members. So if your hospital wishes to have many members joining in, we are happy to offer a package to you as well. So kindly connect with our CAHO team and they'll be able to customize the program as per your requirements. So thank you very much. We have Narayan Pansay sir also who's joined us. Over to you, sir. I think after you finish the second indicator, we lost you. So you can proceed with the third indicator.
Sure.
Thank
Thank
you.
you so much, Dr. Lalu. And my apologies to everybody. There was some unexpected this thing shutdown of my internet. Thankfully, I managed to salvage it, like we were talking about salvaging the myocardium. So I'll now start. Just allow me a moment to share my screen. Yeah. Please confirm if you can see my presentation, my slides in
Yes.
presentation mode.
Yes, sir. You are on indicator 3, stroke.
Yeah. Thank you. So, like we talked about STEMI cases and door to balloon time, very similar is a third, indicator. This deals with stroke patients. This time it is to do with neurological stroke. So, obviously, it is for Department of Neurology. And the percentage of stroke patients in whom a door to needle time, there we had a door to balloon time. Here we have a door to needle time of 60 minutes is achieved. So, let's understand this a little better. What do we mean by neurological stroke or brain stroke? Basically, these are of two kinds. One is where the blood supply of the brain or part of the brain is cut off because of block in the artery. This is called an ischemic stroke. While the other one is where there is a rupture of a blood vessel inside the brain, where it is called a hemorrhagic stroke. And this is important to know this, differentiation, because it is this ischemic stroke which is the one where door to needle time is to be mentioned, because the treatment approach for both these is different from each other. Like we discussed in STEMI cases, similarly for this, the important thing is that the clock is ticking very quickly, because the more time is taken to intervene, more are the chances of irreversible damage being caused to the brain parenchyma. So as you see here, at some minutes after the artery has been blocked off, some part of the brain is at risk of damage, while other is still kind of just hypoperfused, that is receiving less blood supply but may not have been damaged permanently. Yes, but as time passes, more and more area becomes permanently damaged. So it is very important that we measure this and get this treatment of thrombolysis, that is clot buster drug as it is called, as quickly as possible, but within 60 minutes. What is the evidence basis for this? Typically from American Heart Association, American Stroke Association, similarly from Indian Society of Neurology, etc. The door to needle time is taken as 60 minutes from the time of onset of the stroke. Like we also saw importance of evidence-based medicine and importance of a protocol. So you should have a stroke protocol instituted at your hospital. Many hospitals also have a practice of calling out a code, like we have code STEMI. Similarly, there is a code stroke or a code fast, as it is called in my group of hospitals, gets activated whenever there is a neurological stroke patient. What is important to remember is, like there we were diagnosing STEMI versus non-STEMI by ECG. Here, the differentiation between ischemic stroke and hemorrhagic stroke is made by diagnostic imaging, typically by a CT scan. Some hospitals also have an MRI based protocol, but those are very rare. Typically, it would be a CT which is done to see whether there is intraparenchymal bleed or not. If there is bleed, then the treatment does not include giving a clot buster drug or a thrombolysis treatment. So they get excluded from the door to needle time monitoring calculation. So what is door to needle time? Basically, when you have an ischemic stroke, whenever there is a stroke which is due to an artery in the brain being blocked because of some intravascular or intra-arterial block, then it needs to be given a medicine which dissolves this clot, and this medicine is given intravenously. It can be given in the emergency itself, but time is important and it needs to be given within 60 minutes of the time of onset. And every 15-minute delay reduces the chance of a good outcome by 5%. So that is how important it is to be given in a timely manner. So coming to the measure itself, what is the numerator? Number of patients treated with intravenous thrombolysis, that is RTPA as the medicine is called, within 60 minutes of arrival in the hospital, divided by the number of stroke patients who receive thrombolytic therapy. And formula is simple, it's a percentage. How to calculate door to needle time? It is calculated in minutes and comprises the time interval from hospital admission to administration of the recombinant TPA. Inclusion exclusion criteria. One important thing to note here is that neurological stroke can be treated or should be treated with intravenous clot lysis within 4.5 hours from the onset of the symptoms. So anybody reporting beyond 4.5 hours automatically should be excluded. There are also certain contraindications for use of this medicine. Patients who have bleeding disorders or active internal bleeding or pregnancy, etc., are excluded. Similarly, non-ischemic, that is hemorrhagic strokes, are also excluded, and these guidelines are yet for adult patients only. What are the data sources? Typically, you would get this data from the emergency department because the patient arrives at the emergency department. It's an acute emergency, so they would come to the emergency department, and the entire treatment also happens in the emergency department itself. Who captures it? Typically, it would be the triage nurse or maybe a coordinator of the emergency department, etc., who would be doing it. Many of the hospitals have a practice of a stroke sheet, similar to STEMI cases. They also have a stroke sheet for neuro cases, where every time the patient is moved or some action is happening, it gets documented into the input sheet. So it is an ideal practice to have real-time data entry. Of course, the collation of the data can be done on a monthly level and analyzed to assess improvement opportunities. What are some of the problems that might happen? So like we discussed in these STEMI cases, similarly, there may be delays in documentation. There may be some gaps in documentation, synchronization of the clock, etc., by different people may be different. There may be lack of clarity about what exactly is to be measured and when. So this is related to the practice so that it becomes more consistent. As far as presenting the data is concerned, both data tables as well as graphical representation, this is a simple door to needle time being calculated before intervention and post intervention. Benchmark, like Dr. Munkur was also mentioning, ideally would be 100%, but it may not be practically possible to reach 100%. So even ASA has defined 85% for their hospitals. So you could adopt that. You could start with maybe say around 60% and then gradually improve it further. The idea of these indicators to be monitored is to help improve the quality of care and become more and more patient centric. You could also create dashboards for your own hospitals, like I had shown the dashboard for STEMI. Similarly, we have a dashboard for stroke cases. We call it Fortis Acute Stroke Treatment. So in this particular hospital, for this particular time period, if you see that 94.6% of the cases received the thrombolytic drug within 60 minutes of arrival at the hospital. And you could then also look at various subdivisions of these cases. And like I showed for STEMI cases, you can also monitor the median time of door to needle and see whether overall the trend is decreasing or not. Here, lesser time means better time because you are treating more patients in a quicker time period and saving more and more brain parenchyma and thus improving their patient outcomes. What are some of the practices that can help reduce door to needle time? Pre-hospital care or care within the ambulance is very important in improving outcomes in stroke cases. So try and have some mechanism to do that. A quick triage protocol and notification, identification of the stroke and the notification to the stroke team. For example, a code fast or a code stroke as it is called, and making available the recombinant drug because this is a costly drug and many times this may not be available immediately. So try and have a mechanism in which it can be procured and made available quickly for the patient use. Good synchronization between emergency department, radiology department, etc., so that the scans take place quickly. And many times, because this is expensive treatment and time is of essence, having a system for consent management and financial counseling, etc., also play a role in reducing the door to needle time. Coming to the next indicator, indicator number 4, and this, according to me, is the probably the most difficult indicator to measure for any hospital, is the percentage of hospitalized patients with hypoglycemia who achieve target blood glucose level. Now we need to remember that the burden of diabetes in India is very high. Many of the patients who are admitted to our hospitals are admitted either because they are diabetic or they may be admitted for some other condition, but their glycemic control, glucose control worsens during that period, and they may be put on insulin. It's a standard practice before major surgeries, etc., or in sepsis, etc., that patients need to be shifted to insulin. Now, when the patient is on insulin and in the hospital, there are high chances that such patients may develop hypoglycemia, which is defined as a dip in the glucose level. And when that happens, that can cause higher morbidity and mortality and prolonged hospital stay, etc., for these patients. So that is why it's an important clinical indicator for glycemic control. What do we mean by glycemic control? Typically, the accepted range is 140 to 180 milligram per deciliter, but it can vary from ICU to ICU. So it is always good to talk to your critical care heads or to your endocrinologist before taking it as 140 to 180 milligram per deciliter. As far as hypoglycemia is concerned, a blood sugar level which is less than 70 milligram per deciliter is considered as hypoglycemia. There is a catch in this. I will come to this in a couple of slides. It is well established that hypoglycemia is problematic and that adequate glucose control in hospitals is required. So guidance and evidence-based medicine guidelines come from ADA, similarly from Indian associations, etc., are well available, similarly from ICMR also. Like we talked about a STEMI protocol and a stroke protocol, your hospital should also institute a hypoglycemia management protocol. And it would look something similar to this, that if the capillary blood glucose is less than 70 milligram per deciliter, then what would be the approach? If it is less than 50, then what needs to be done? If it is between 51 to 69, then what needs to be done? Retest after 15 minutes, etc. And how the sample is to be taken, how it is to be measured. Many hospitals have a sliding scale which is used for insulin management, etc. So the protocol needs to be well managed with the various measurements, etc., timely measurements which need to be done. As far as the measure is concerned, the numerator is number of patients with hypoglycemic episode, that is blood glucose less than 54, and who achieve the target glucose during the same hospitalization. Now, you would be wondering, 2 slides back, I was telling you 70 milligram per deciliter. If the blood glucose goes below this, it is considered hypoglycemia. Well, if it goes below 54 milligram, it means that the intervention needs to be done immediately. And this is the value that NABH has defined in its KPI. So while the ADA and the clinical definition may be 70 milligram per deciliter, NABH has given 54 milligram per deciliter for their KPI reporting, and you need to comply with that for NABH reporting purposes. So it would be better if the hospitals take all cases as less than 70 in their count and separately report those less than 54 for NABH reporting purposes. As far as target glucose level is concerned, like I told you, it can vary in different settings for different care groups. For example, the medical ICU and surgical ICU may have different target glucose levels, and one needs to be cognizant of this fact and should discuss this with the clinicians before setting up the targeted glucose levels. Inclusion exclusion criteria, this is in that sense pretty straightforward, that all adult hospitalized patients with documented hypoglycemia should be included, while patients below 18 years and sometimes end of life patients, etc., those on palliative care can be excluded because you are not particularly concerned with the target blood glucose level in this set of patients. How to capture? Well, if you have your blood glucometers, etc., integrated with the EMR or the HIS, it is simpler. Many of the times it is not, so you have to rely on medical records, whether they are electronic medical records or physical case records. You need to look for the sliding scale for the glucose values and whether the correct treatment, for example giving dextrose drip, etc., has been instituted or not. Usually it would be the nursing team who would be responsible for reporting this, because they are the ones who enter this data into the case files. Obviously a retrospective audit can be done by the quality team or by somebody else who is tasked to do that, and then it should be reported. The frequency, like I said, is real-time data capture or at least a daily audit, and then it could also be a retrospective audit at certain defined time periods. Please remember, this indicator is a little difficult to manage because the number of patients who are admitted in a hospital may be very big. Many of them would be diabetic. So the instances of hypoglycemia may go, undetected, and that is why it is very important to be aware of this, indicator, and then be able to monitor and measure it. Typically, some of the entries may be missed because it's a frequently done test, sometimes between shifts or during takeovers, etc. It may not be entered into the case file, and if it is not entered, it may not be picked up for the monitoring. What are some of the solutions for this? First is, of course, being aware that hypoglycemia, it's a fairly recent indicator as compared to, say, the door to needle time or the door to balloon time, etc., that we were talking about. So awareness and training of nurses, quality teams, etc., around this is very important. Standardized templates, be it for EMR or be it for physical case file with glucose follow-up, etc., regular drills during the ward training periods, etc., to be aware. Having some triggers, for example, whenever a dextrose drip is ordered for a diabetic patient, it should trigger something that this needs to be investigated, etc. And if you have direct device integration with your EMR systems, then the low blood sugar could also trigger alerts in the EMR. As far as benchmarking is concerned, the expectation or ideal benchmark would be at least more than 90%. But you can look at your own hospital's historic data and set up an internal benchmark accordingly. Like Dr. Munkur also mentioned, that if you have around 50-60% compliance, set your target to be able to move towards 90% and work towards this. This is a good example which can be taken up for a clinical audit or a quality improvement project in your ICUs and wards. How to interpret or what to look for? Look whether there is consistency in various departments. Some hospitals some departments within the same hospital may be able to meet the target blood glucose level in many of their patients, while some may not. It's always good to compare off routine hours versus routine hours, or weekdays versus weekends, because typically the patient monitoring suffers during the weekend period, because as we say, our guards may be a little down in hospitals at that time, staffing problems may be there. So all these help you pick up points or opportunities for intervention, so that your overall quality improvement take place. Coming to the last indicator, this one has to do with nephrology department, because that's where dialysis patients are. So percentage of patients undergoing dialysis who are able to achieve target hemoglobin levels. So let's understand what this is all about. I'm sure all of you know hemodialysis, the procedure. There are various types. There is maintenance hemodialysis, there is peritoneal dialysis, etc. We will stick to hemodialysis. And basically, in patients with chronic kidney disease, hemodialysis is undertaken sometimes twice a day, thrice a day, etc., or maybe even more, depending on the patient's condition, where the blood is cleaned or filtered out outside the body, and returned inside. It's basically replacing the work that is done by the kidney. Now, anemia itself is common in chronic kidney disease due to various pathophysiological reasons. But it is important that the hemoglobin or the anemia be measured and the hemoglobin levels be maintained between, say, 10 to 11 or 10 to 12 gram per deciliter. Why is this important? It is important because if the patients are chronically and severely anemic, then there is increased risk of cardiovascular complications, hospitalizations, and even death. While a high hemoglobin may cause, or may have increased risk of thrombosis of the arteriovenous fistula, which is carried out. So that's why this target range is defined very clearly, and that should be maintained in hemodialysis patients. So in the measure, what is the numerator? Number of patients who are undergoing dialysis who are able to achieve the target hemoglobin levels. Now, what is the target hemoglobin level? It varies from guideline to guideline. For example, the internationally or globally accepted evidence-based guidelines, which is by KDIGO and KEDOKI, is less than 11.5 gram percent. While the Indian Society of Nephrology, it is 10 to 12 gram percent. NABH in its KPI has defined this as 11 to 12 gram percent. So you need to discuss with your nephrologist team as to what is the target hemoglobin level that they are comfortable with and set it accordingly. Obviously, the hemoglobin needs to be monitored and measured. Typically, it is done at a monthly level, and it should be captured or measured pre-dialysis when the patient has come at least once in every month, ideally, because depending on the patient cycle, etc. In some hospitals, it may be 6 weekly also. The formula is simple, and frequency is it is to be reported at a monthly level. What are some of the inclusion and exclusion criteria? Inclusion criteria is straightforward: patient on maintenance hemodialysis. Exclusions: patients on other form of dialysis like peritoneal dialysis, or those who are on hemodialysis for acute kidney injury. Similarly, patients who are admitted to hospital for related or unrelated conditions, those who have received renal transplant, etc. So those are some of the exclusion criteria. Similarly, one of the problems which happens in dialysis is regular attendance of the patient or regular sessions of dialysis. For example, if the patient is undergoing 3 sessions per week, then at least the patient should be attending dialysis at the same facility for a minimum of 11 sessions a month. Because if not, then the adequacy of dialysis and monitoring itself becomes questionable or difficult for the hospital. Similarly, for patients who are on 2 sessions per week, it should be defined. You can discuss with your nephrologist and set the exclusion criteria accordingly. The data capture: thankfully, most of the hospitals or dialysis centers have a logbook or a patient record in the form of a diary or a log which is maintained, where they meticulously and the detailed documentation is done. All the dialysis treatment records would have a hemoglobin capture section for each dialysis session, if the hemoglobin has of course been done in the pre-dialysis session. But this record would be invaluable for getting this data for this particular indicator. Responsibility typically would be with the dialysis technician or the dialysis nurse of the dialysis department, and of collating the data, it could be with the quality team. There are also hospitals which use dialysis specific softwares or EMR systems, etc., and they have quality monitoring dashboards. Some of the dialysis manufacturing, the companies which manufacture dialysis equipment, or big outsourced partners who run dialysis business, also have their own quality dashboards, and they could also be used for this particular indicator. uh, Now, obviously, hemoglobin is just one of the indicators. Dialysis would have others also, and it's a good idea to have patient-wise monitoring of the different, parameters, seeing whether they are able to maintain, let's say, the target hemoglobin level or not. And it could be monthly measure. For example, if you see here, this particular patient has been able to maintain his hemoglobin around 12, which would be the expected range, depending, of course, on the guideline that you use. Analysis and interpretation: as far as benchmark is concerned, particularly in Indian patients, it may be a little challenging. because our compliance overall, one is that the incidence of anemia is anyway low in our population, and those who are on CKD or diagnosed with CKD, the anemia is even a bigger problem. So it may not be possible to have benchmark or some of the Western, healthcare systems applicable to our systems. So you can check or monitor your own baseline data and come out with the benchmark. A good target would be say around 50 to 60%. Even that could be difficult for some of the hospitals, but you can then practice, to monitor your practice and compliance and see how you can improve the follow-up and the anemia control for these patients. If you are a network of hospital, you could also compare between different hospitals as to how their dialysis centers are performing. Uh, so, a lot of data being generated overall, as we have seen, but ultimately, what is the purpose of collecting all this data, different indicators that Dr. Munkur and I have covered today? Ultimately, this data is information, but what is required is to convert it into meaningful actions so that we are able to overall improve the quality of services that we are providing, building a culture which supports learning and improving. Always remember, dealing with clinicians, try and improve the practice. Don't question their knowledge. That's a difficult area to work in. Like I said in my opening statement, the purpose of accreditation bodies and their scorecards is not to question clinicians. It is to onboard them into the quality monitoring journey. And that should be the spirit with which we engage with our clinicians so that they share, support, and facilitate this change. Thank you so much. I'll stop here.
Thank you so much, sir. I think the intent is very clearly spelled out. It is not to find fault or to try and put them in in the spot, but to make the clinicians champions in measuring. And quality is all about measurement, and outcome measurement is the crux of improving clinical care. So let's get engaged with the clinicians and try and support. It's more a supporting role that quality teams can provide. So with that, let me quickly take up some questions. I think Dr. Sunil has graciously answered to most of the questions. Anything specific that you note, Sunil sir, here? I see you have answered to several questions here.
Not all the questions have been answered.
Answered.
Yes, sir, there is
One
no
question is, we do not have EMR full-fledged. How do we calculate from each ward? Particularly, I think, as you rightly said, the hypoglycemia management, and that's going to be a challenge with point of care testing and the sliding scale available. So, have you, how are you managing in your own organizations, or what would be the recommendation?
there is a new indicator which also talks about point of care testing and how the action has been taken on the reports of the point of care testing. So we have started using a director register for these point of care testings, including blood sugar monitoring. And if there are anything in these registers, if there are anything, then it will be immediately taken care of. That's
Yeah.
how we have started. So you have to generate your own mechanisms in your hospital based on your complexity of the organization.
Absolutely. I think it is just the context, your own organization. In our case, actually, the nurses do the billing. Even if it is point of care testing, it is billed. So we can actually take them from the billing data also and then retrospectively go back and check. That's another way of at least getting a sample. Now, Narayan sir, is it important that we do every case, or can we say once a week we do, this ward, another week, another ward? Is that a better way? Particularly large organizations with the 1,500, 2,000 beds may have such difficulty with almost like 50% of the patients who are diabetic. What are your thoughts?
Not only for large hospitals, to be honest, it would be a challenge for small hospitals also, because measuring anything in a clinical area can be challenging because of various reasons. So it's always good to start small, because sometimes you may also have to stop and recalibrate what you are doing. There would be different opinions. Some clinicians would come with some other guideline which they want to follow, and for you it would be difficult to say no, we have this definition only, and because NABH has said, we monitor only this. So it would be difficult to do this in many hospitals. So it's always a good area to start small. If you're a large hospital, teaching hospital, etc., you could start with few wards or maybe one ICU, etc., and then spread it over the period of time. See, the intent is to see whether you are wanting to improve your quality of care overall for maximum number of patients over a period of time. And NABH also, looks at it from that intent. So it's not necessary to cover 100% of your patients, but the intent would be to reach to 100% at some point in time in the foreseeable future, ma'am.
Absolutely. Probably with all the EMR enablement, we are anyway starting new. So once we start capturing and in a very gradual approach, we could increase the frequency, the numbers, and then eventually reach a better system. That's probably what we should be trying towards.
One
Sunil sir,
point
you
to
want to
add,
add on? Yeah.
yeah, one more point to add what Dr. Narayan Pence has already told. See, it is the indicator which says that you need how often the target sugar levels are reached once there is hypoglycemia. You may be doing so many GRBS or blood sugar levels in the bedside, but many of them may not have actual hypoglycemia. So it's only those hypoglycemic patients you need to monitor and how the target is achieved. That is what.
Absolutely.
So it may be, well, maybe I can say 5 to 10% of cases may have hypoglycemia. That's the thing.
Yeah, but a new system has to be developed to capture
Yes,
that.
yes,
That's the
yes.
question. Yeah. So I think there are several questions about this tumor board, whether it should be daily, monthly, weekly. I don't think we should fix anything here as part of the frequency. You're a large hospital, you will be doing almost every day 10 tumor boards also. What are your thoughts?
Yeah, I
Sunil?
have already put that based on the oncology patient load, you may have to decide on the frequency. Sometimes it may be daily and or ad hoc also. If there is a complicated case which needs to be immediately treated, probably ad hoc meeting also can be done. Otherwise, you can have meet weekly or bi-weekly if the case load is more, or if it is once in 2 weeks or once a month is also fine. However, some of the straightforward cases you need not go. It need not go to the tumor board
Yes.
unless there is a deviation required because of the complexity of the case. Otherwise, if it is a straightforward case, you can just put it in the tumor board and say that this is being discussed. That's it.
Yeah,
Yeah.
if I can just add to that, many hospitals, particularly bigger cancer centers, they also have specialty specific tumor boards now. Let's say pediatric oncology or hemato-oncology or even neuro-oncology, etc. So you have to plan according to your case mix and your, case load. And like Sunil sir rightly mentioned, that for some straightforward cases where you have your set algorithm or protocol which you are following, you may not need to take it to the each and every case to the tumor board.
I think we have to make that very clear. That's a misinterpretation that's going around that every case has to almost go to the tumor board. If that is so, it's going to be very, very complicated. And I think our oncologists in most hospitals are already standing with the guns. So I think that clarity is extremely important. Thank you for that. I don't see, except,
Uh, there
yeah,
are some
go ahead.
questions from Dr. Pence's topics.
Yeah, yeah.
In the HB level KPI, should we take individual patients or individual dialysis visits?
So as far as NABH is concerned, they have defined it very clearly, sir. It is total number of patients undergoing dialysis. So I understand where this is coming from dialysis sessions, but ultimately hemoglobin is not measured every dialysis session, right? It's measured once in 4 weeks or 6 weeks. So sticking to the number of patients on hemodialysis would be more straightforward and representative.
Absolutely. Here, there's another one, hemoglobin. Again, a lot of clinical doubts. Maybe yeah, hemoglobin in dialysis. Clinicians are saying that it's difficult to reach hemoglobin 11 to 12. If patient reach also, it will cause complications to patients.
So
Yeah.
fair enough. Like I said, the idea is not to question clinicians. Again, see, if your clinician has said for himself that, okay, I'll keep the target between 10 to 11, that's okay. Nobody is wanting that you go strictly to 11 to 12. For
Yeah.
reporting purposes, you may still report it on 11 to 12. But for your internal purpose, you can still see how many of them are within this range. If your clinician has got a evidence-based guideline backing that, 10.5 is what I am targeting, it may be okay to do that as long as you are linking it to an established guideline and a protocol. That is fine. Indian setting is different. If there is Indian data which says, like I gave you the example, Indian Society of Nephrology, the guideline is different as compared to what the global guideline is. So you have enough scope for clinicians who want to practice evidence-based medicine to be able to do that. And even if there is a difference of opinion, please don't go hammer and tongs on them
Exactly.
only with a document that says it is 11 to 12 and we need to make it 11 to 12. Ultimately, patient care is the clinician's responsibility. It's not the quality department's responsibility.
Absolutely. I think that is the most important message that we have to put across. This is not something that is set in stone. This is only a guidance document, and it is something that we cannot achieve overnight. Every organization will have its own, definition of what they are going to be capturing. Some will say 11 to 12, some may say 10 to 11. Whatever it is, you start capturing. The idea is to start capturing the data and eventually we improve upon it. It may take about another 5 years to 10 years to actually perfect the 18 indicators. But the idea is to start somewhere. I think that's the main idea we should have in our mind rather than having that paper and saying NABH says 11 to 12, you stick on to that. Then acceptance is never going to come. You're going to have difficulty capturing the indicator.
On the contrary, it may lead to unnecessary hostility,
Yeah.
with the measuring team. I think one question is there: if a patient undergoes GRBS 10 times, how to monitor? So, like I said, this is a very difficult. Probably hypoglycemia is the most difficult, indicator to monitor because, like I said, the incidence, the number of patients with diabetes, the number of instances which could be there, and number of times glucose gets measured. It is indeed difficult, and that's a classic case where you can start small. You can start with one ward or two wards or one ICU, and then gradually spread it, what Dr. Lalu was mentioning earlier.
Absolutely. I think we have run out of time. We started at 4:30 and we are now at 6:18. We have another session as well. And I'm sure we can answer to all your queries. Write to us, office@kaho.in. Both the experts are available. We are more than happy to actually, I thought it's good that we prepare a FAQ document and also put it up in the website for the benefit of everybody. So if you have very specific questions, kindly write to us office@kaho.in. I would like to reiterate that we have a very specific training program that we are going to be starting, the Masterclass on clinical indicators. It is going to be extremely useful for departments, for hospitals, for clinicians to be part of this Masterclass series. And I would encourage the hospitals to register and join this Masterclass series. It's going to be 1.5 hours every week. And we are going to have 18 such sessions, very interesting sessions. And the faculty are going to be experts from the hospitals that have already mastered capturing these indicators. If I may request the Kaho team to kindly put up the list of hospitals and the topics that we are going to be covering, it will be very useful for the audience. Meenakshi, Rabina, can you please put up that?
Yes, ma'am.
So the next masterclass session is on the 12th. Don't miss that. Another set of 9 indicators will be presented by Dr. Sanjeev Singh and Dr. Nirmal Frederick. So what's going to happen? 18 weeks, we are going to have very specific department-specific indicators presented. Almost 7 to 8 indicators per department, starting from emergency department, cardiology, cardiothoracic, obstetrics, gynecology, IVF, pediatrics, neonatology, nuclear medicine, radiology, radiotherapy, orthopedics, oncology services, gastroenterology, HPB, general surgery, ENT, ophthalm, neurology, diabetology, nephrology, dialysis, derm, blood bank, laboratory medicine, and all the PMR, physiotherapy, occupational therapy, therapies, prosthetics, orthotics, clinical dietetics, all transplants, dentistry, and oral maxillofacial surgery. So we're going to cover the entire gamut, and I'm sure it's going to be very interesting because pioneering institutions are the ones who are going to be taking up this and running the show. So I would encourage certainly all the hospitals to join, particularly encourage your clinicians to join the Masterclass series. They can just join for their own sessions. It is not necessary for a cardiothoracic surgeon to sit through the entire set of 18 departmental indicators, but at least on the day when cardiology and cardiothoracic is being discussed by Fortis Healthcare Limited, it will be interesting for them to be part of it. We can also learn from them. They may have a lot of value additions to what we are going to be putting together. And all the 18 presentations will be shared to you. It will be made available in the Kaho Resource Center. Thank you, dear friends, for joining. A very special note of appreciation and thanks to both Dr. Narayan Pense and Dr. Sunil Mundkur for taking your time, for putting the presentations together, and a very, very informative session. We've all learned a lot, and I'm sure all of us have many questions. But considering the time, we will write to you, sirs, and please help us with all the answers. We really look forward to the presentations. Many of them have asked for the presentations. We'll be very happy if you can share the presentations with the audience. Thank you once again. Narayan sir and Sunil sir, a final word from both of you.
So if I can go first, thank you so much, Dr. Lalu, and I'm glad that the participants found the session useful. And like you said, there would be more questions. There are quite a few questions which we could not answer. We'll be happy to share with the CAO team later on, and they can be circulated to the participants. And this is something which is very important. Like I said, the purpose of measuring an indicator should not only be to satisfy NABH. There is a larger purpose which is there at stake, and we should all align it with the idea of promoting evidence-based medicine at all our workplaces. So good luck to everybody in implementation, and thank you so much.
Thank you so
Thank-
much. Sunil sir.
Thank you so much, madam, for giving me the opportunity and making me read on this. Because we have to talk on evidence-based medicine, we cannot be talking like that. So it was a very interesting topic. Thank you, Naren sir, for those learning experiences we had today. And thank you, Secretariat, for the fantastic support. Thank you, one and all.
Thanks,
Thank you, sir.
everybody.
Thank you so much.
Thank you all for joining. And next week, same time, 4:30 to 6 p.m., we have another free webinar on the left, another set of 9 indicators. Look forward to meeting all of you. We had record number of registrations, 998 registrations. And we could not actually share the link, only 500 could join. Both on Facebook Live and YouTube Live, more than 150 to 200 people have logged in. So that's the interest in the country, and I'm sure this is going to go to the next step of excellence, and it's going to be very, very useful. Thank you so much. All the best. Have a great evening.
Thank you.
Bye-bye.
Thank you. Thanks, everybody. Bye-bye.
Thanks, Meenakshi. Thanks, Rabina. Thanks, everyone.
Thank you.